tried to reach them severally and they are not coming on. We'll just excuse them from the group since they are very busy for this period. So I'll just share the book so that before Dr. Charles Okorie comes up, we would have got some numbers. Where the last questions. Tomorrow we might just do a couple of presentations, then roll out new timetable for the final phase of the MCQ. That's the recall for West Africa and national. So please, let's be prepared. We're almost reaching the ending point. So I'll share the question now. I expect Aminatu and Zakia to be on the page. But if they are not on the page, we'll just take up the backups and let them roll with it. Let me check who's supposed to do backup to them. All right, Dr. Adebi. Dr. Adebi. Adebi.
Yeah, good evening, Dr. Kopa.
All right,
good
so
evening.
If Dr. Zakia, come on, you'll be the one to take the next session, please.
Honestly, I didn't check, but we'll do it together.
Yeah, we'll do it together so that we can just finish up. Our target, let's finish it today. So that by tomorrow, we're doing a lot of presentations. Then by Monday, we'll start the recall.
Okay.
Yeah, and then, from next week, we'll have a lot of presentations too. We have Jennifer to present. We have a couple of presentations to do. So we continue to present, Alex to present. All right. Good evening, class. Good evening, everyone. Again, Ajayi, Faith, Mr. President, Henry, and my beloved sister, Jennifer. She has to be around before we start. Jenny? All right, she's not around. So we'll just start. Dr. D.
I'm here. Hello, Chief Okopi. Good evening.
Yeah. Also misbehaving, so somebody should help. Hello. Alex to be. Alex. Alex to be.
Sorry, I'm on a call, sir.
Make me transfer the host to me, please. Alex, transfer the host, please. Yeah, thank you.
Done, sir.
Thank you. So, Dr. Adebi, please, you're on set. 1, 2, 3, go.
Okay, good evening, class. So starting from section I, starting from question 1, says the inlet ventricular septal defects. A is a perimembranous VSD adjacent to the medial papillary muscle of the tricuspid valve. B is associated with a secondum ASD. C is associated with premium ASD and placed adjacent to the tricuspid valve. D is located adjacent to the pulmonary valve. E occurs in any location within the mid or apical walls of the interventricular septum. So I'm looking at the interventricular septum. They said the inlet. Looking at the inlet, I think the inlet should be at the entrance of the ventricle. That is, it should be somewhere around the around the atrioventricular valves at that junction. So I'm looking at something that will involve around either the mitral or the tricuspid valves. Okay, so usually I would have expected that's probably maybe they will give us things like the AV canal, the one that is connected to the AV canal around that region. So definitely, if you look at it from that perspective, it shouldn't be the one. It shouldn't be here. You guys, perimembranous VSD adjacent to the medial papillary muscle. Papillary muscles are deep down towards the apex, so it shouldn't be that one. Then the B that I say is associated with secondum ASD. Okay, let me look at the other ones. It's associated with premium ASD, placed adjacent to tricuspid valve. This one is around the valve. Then D is located adjacent to the pulmonary valve. No, the pulmonary valve is way high up. Then occur in any location within the mid or apical walls. No, it shouldn't be around that area. So it should be around, since it's inlet. So I think it's between B and C. But looking at using the tricuspid valve, I think it should be more of C. I don't know. Does anybody has any idea? I think for me, I think it's more of C. Hello? Dr. Kopi, are you there?
Hello,
Hello,
Dr.
can you hear me?
Adebi. We can hear you.
Yes. Okay.
We can hear you.
I think it's more of the premium ASD with the tricuspid valve involvement. That's option C.
Okay, that's the answer Prof actually chose, and it also seems like you said in the inlet VSD should be in close proximity to the tricuspid valve, and the premium ASD actually lies lowest among the other ASDs. Actually lies very close to the AV cushion. So an inlet VSD would likely happen around that area if it's happening. So that's
thank you.
should make the answer correct, yes.
As endocardial cushion defect, once there's ECD, then of course you see a premium ASD and then you see an inlet PSD as well.
All right, thank you. Wait, this question too, I don't think I've read it. Which of these qualifies a patent foramen ovale to be categorized as simple? So I don't know aneurysm of the interatrial septum, interatrial thickness of 7 mm, multiple openings into the left atrium, tunnel length greater than 7. I actually have no idea about this one. I don't know if anybody has. Hello? Hello?
Hi, Dr.
I
Debbie,
have
we
no
can
idea
hear you.
about.
We can hear you.
Okay.
I have a note from the last time where we talked about the fact that the patent foramen ovale can be simple or it can be complex. And there are different things that characterize the different types. One of them is that the total length of the opening for a simple PFO should be less than 8 millimeters. Then they said thickened ostium secundum. Don't really understand what I wrote there, Sha, but there's no other defects of the PFO. That's, for example, an ASD shouldn't also be there. Then if there are multiple openings in the left atrium, it usually will mean that it's a complex PFO. So, and for the aneurysm, I don't have that information. I don't know if someone else maybe has that. But an interatrial thickness of 7 millimeters. I don't have that either.
So that should make it a simple.
I don't know. I don't have that one. What I have is the tunnel length. It should be less than 7 millimeters, less than 8 millimeters. So that less than 7 millimeter is fair enough. Then the multiple openings in the left
So the
atrium
tunnel
also.
length here is saying greater than 7.
Yeah, it said greater than
tunnel,
7. Okay.
So that means that shouldn't be correct.
Yeah, that shouldn't be correct. Yes, it should be less than 7. Yeah, so we're looking for the correct one, right? Yes. So multiple openings in the left atrium is a complex PFO. Tunnel length greater than 7 millimeter is also a complex PFO. Then I don't know for the aneurysm, but well, I would expect that if there's an aneurysm, it's no longer simple because it will take some complexity to sort that one out. But probably we'll need to check. There must be a place where it was differentiated. For the interatrial thickness.
Thickness of, you said anything less than 7. Or sorry, you said less than 8, right?
Yes, that's what I have for tunnel length, less than 8.
No, I mean in the interatrial thickness of. Did you mention interatrial thickness?
No, what I have is for the length of the opening.
Okay.
Yes. So maybe if someone could just check it out and tell us any additional information there may be.
Let me see if I can check. Sorry, I want to check. I couldn't find that here. Okay. I found something here.
Okay.
It says for the complex, it said long tunnel length greater than or equal to 8 mm.
Okay.
Then multiple openings to the left atrium, atrial septal aneurysm, hybrid defects, thick secondary septum greater than 10 mm, eustachian ridge, eustachian valve or Chiari network. So for simple means none of these ones. Anyone that has any of this one is a complex. So if you don't have any of this,
I bet with that complex.
So read it again.
Okay. Long tunnel length of greater than or equal to
Or can
8
you share
mm.
the screenshot and
You
share
said?
the document? Can you share the document?
Okay.
Just share it, yeah.
Okay, I was actually checking on laptop, so I'll find a way of downloading that table and send it.
Okay, just read it before, so that in case you forget to download it, you have the information.
Okay.
Just read it out.
Long tunnel length greater than 8 mm. Okay, multiple opening to the left atrium, atrial septal aneurysm, hybrid defects, thick secondary septum, atrial septal aneurysm. Sorry, okay, I think I've mentioned that one. Sorry, please. Thick secondary septum greater than or equal to 10 mm, eustachian ridge, the eustachian valve or Chiari network. So any of that will make it a complex PFO. So if we have none of that, it's simple.
So if we check the answer now, aneurysm of the interatrial septum is for complex multiple opening, tunnel length
Yes.
greater than 8, but here it says 7.
Yes.
All right.
Seven means it's less than 8, so it's still a simple.
So that secondary thickness you say is what?
You say the
Greater
tunnel,
than or equal to 10 mm.
the tunnel
Hello?
length greater than 8.
No, not tunnel length. That thick secondary. What do you say? It should be what?
Anything greater than or equal to 10 mm is complex. Though they gave so 7 then means that 7 is simple since it's not more than 10. That's a good idea. I don't know if you understand what I'm saying.
Yeah, I understand. It's not up to 10. It's not up to 10.
It's not,
And
that makes
yeah,
it a
so
simple.
it should be simple.
Yes. So that makes the correct option to be B.
Okay.
All right.
So what then makes option tunnel length greater than 7 mm? What makes it wrong?
Yeah, there are more. Let me share one document with you.
Okay.
There are more.
Oh, okay.
There are more in this country. There are more.
You mean in this country ruled by Balabulu?
Balabulu, our president-elect, no matter anything, he's our president. You don't want Japa. Okay, so let me read it out. Tunnel length greater than 8 to 10 millimeter of mercury complex. Let's say standard. The simple PFO have the standard anatomy. That means the following will not be part of the simple PFO. So as he said earlier, tunnel length greater than 8 or greater or equal to 8 millimeter, multiple opening to the left atrium, atrial septal aneurysm, excessive movement of the atrial septum, large opening, shunt at rest, hybrid defect, thick septum secundum, greater or equal to 10 millimeter, prominent eustachian ridge, eustachian valve or Chiari network, angle between the PFO and IVC less than 10 degrees. Did you get it?
Yes, sir.
Yes.
less than or equal to 10 degrees. So that's large openings and then shunt at rest. In addition to the excessive movement of the atria. So the simple is without this. Clinical condition associated with PFOs, migraine headache, systemic arterial embolism, decompression illnesses. All right. Can go ahead, sir.
Okay, question 3. One of these applies to patent foramen ovale in contrast to atrial septal defects. So the difference between PFO and the ASD. Exceptionally associated with intermittent left to right shunts. For PFO, I don't think so. B, exceptionally associated with permanent right to left shunts. C, typically associated with intermittent right to left shunts. D, typically associated with left to right shunts. I know it's not left to right shunts. So option between B and C. Now, it shouldn't be a permanent too, because if it's a permanent, that means from childhood, anybody that have PFO will definitely be having symptoms of right to left shunt. So I think it's more of C. I may not be able to, but at least from if it's permanent, it should be from birth. That patient is going to be having cyanotic symptoms. So I think it should be an intermittent one. Should be an intermittent one. Does anybody have any better explanation?
So that should be A, Abi?
C.
Huh?
C.
C?
Typically, ASD is left to right.
But C is saying right to left now.
Intermittent. So they are talking about PFO.
So
Not
PFO.
not ASD.
Hello.
Yes.
I don't know. I don't understand how we're answering this question. Because I mean, you think one of these applies to patent foramen ovale in contrast to atrial septal defect. Oh, sorry, I thought it was except at the end.
The question there is in contrast.
But in contrast, that is what we find in PFO that is not in ASD.
You can find right to left shunt in ASD.
Sorry.
So patent.
So if it's ASD, typically ASD is left to right, except in the Semenga.
Yes, exceptionally associated with permanent right to left shunt. If there's a Semenga, typically associated with left to right shunt. What is even trying to?
So it doesn't look like they are discussing. They are not talking about Semenga here.
So what is he saying now in this question?
Because otherwise, he will have said advanced ASD or something, long-standing ASD. So ASD are fresh, and then PFO. So I'm looking at this PFO. So I'm saying between option B and C, that's the right to left.
No,
but then
I think it should be the answer.
What?
C.
That's what I'm saying, that if PFO is right to left shunt, and we are saying there is a permanent shunting right from inception, right from birth, that means the patient should actually have cyanosis from birth. And typically,
Yeah, so it's
they
actually
don't have that from
intermittent.
birth. So it's usually an intermittent thing.
Yes.
So that's why I think C should be more like it.
Yeah, I think from these options, that's the most appropriate.
All right, let's hit the ground running. That's the most appropriate, actually.
Okay. Which of the following is the
Sorry,
commonest
please.
type of...
Why is it not B?
It's not B because it's not permanent.
Oh.
The right to left shunt in PFO is not permanent.
As a manga that
It's when there's SMenga, that's when it needs to be there. But normally, normal
Yes,
PFO
right.
is not permanent.
Okay,
It's
okay.
intermittent. If not, if it is permanent, then it will be part of the cyanotic congenital heart diseases.
True.
Yeah.
Okay, thank you.
You're welcome, brother.
Maybe to just clarify that further.
Sorry.
In a normal person, hello.
Go ahead, Dr. Conte, please.
Yeah, in a normal person without a Semenga, your left-sided pressures in the atria are higher than those on the right. So if there is any shunt, blood will attempt to flow from left to right. But in PFO, like Dr. Gudia said, there is a valve effect of the foramen ovale. So when blood tries to flow from left to right, the valve will shut down. But intermittently, when you get into a situation wherein the pressures on the right outweighs that in the left, with certain maneuvers, for instance, Valsalva maneuver or doing certain strenuous activity, then intermittently, blood shunts. And that's how people can end up having a paradoxical embolus when they have PFO.
Thank you.
Sorry, what's the answer in Pro's book?
The answer we explain is correct, even if Prof book says C.
Yeah.
Okay.
Yes, in addition to the explanation. I hope you got the explanation, Dr. Atu.
Well, yeah, I got it actually. Thank you.
All right, so well done. All right. Okay, so Adebi, hit the ground running.
Okay, so question 4 says, which of the following is the commonest type of ASD? I know you said ostium secundum, I might not be able to remember the percentage, but it's the ostium secundum followed by the premium.
The second shall be the first, while the first shall be the second.
Okay.
I don't know the percentage. Does anyone have the percentage?
Secondum is 80%, and the primary is 15%. The primosus, that one is 5 to 8%.
Okay.
Secondum is the commonest, and it's about 80%. And the primary is 15%.
Primum is 15%. Then the others.
Then the others.
Ayodeji, you know that your presentation. We need to read it.
No, I think secondum is the commonest. That's it. It's the commonest.
Yes, secondum is the commonest.
Followed by the primary. That one is 15%.
And it presents with a left boundary brown block pattern.
Yes, sir. Yes, sir.
Dr. Ayodeji, that your professorial presentation needs
I'm
to
sending
be
the tomorrow by Thursday.
it needs to be laminated.
Yes, sir.
And put everywhere on NCS page. So please send it again.
Okay, sir.
By this statement, you have been granted a professorial degree from this group, a professor of the U wave of the ECG.
Okay, sir.
Thank you. Let's hit the ground.
Sorry, my network might be fluctuating. They just took a light, the router shut down. So please, in case we go off at any time, please, while they are trying to put on here. So question 5 says, defect with the fossa ovalis best describe one of these fossa ovalis. I can't remember for that values. Coronary sinus ASD, ostium premium defects, secondum defects, sinus venosus ASD. Sorry, I can't remember for the values.
Secondum. Secondum is within the fossa ovalis.
Okay.
It's
Thank
within.
you.
Okay,
Okay.
Dr. Ayodeji,
Yes, sir.
I beg, please just be around so that you can give us some tips since you presented this topic. In case he goes off, please. All right, Dr. Adebi. Okay, you can go
Okay.
ahead, please, Dr. Adebi.
Okay, which congenital heart disease is detected by auscultating over the spine? Over the spine. A, atrial septal defects. B, coarctation of the aorta.
5.
Yes, now. We said fossa ovalis is.
Fossa ovalis is PF4, Abby.
No, we said secondum defect. That says secondum lies around the fossa ovalis.
Okay.
The fossa ovalis is within the secondum. The septum secondum grows up from the floor. If I remember correctly, it grows up from the floor towards the roof. The primum is the one that grows from the roof towards the floor of the embryonic atrium. So inside that secondum that is growing from the floor towards the roof of the atrium, there is a defect. That defect is the foramen ovale or the fossa ovale.
The secondum actually grows from the roof. When the ostium premium is going down, before it gets to the AV cushion, there's a defect that comes at the roof.
Okay.
So when that defect comes up, it will mean that when the defect comes like a physiological, well, it's necessary so that there's blood flow maintained from the right side to the left side. So just as the ostium premium is meeting the AV cushion, that's at the bottom of that, at the roof of the atrium, the ostium secundum starts to grow to cover that defect that has come up from the ostium premium, it occurs like by an apoptotic mechanism. So that ostium secundum now grows downwards to meet the lower part of the ostium premium. That I think I'm making it a bit complex. Okay, so basically,
no, I think listen. You know, there is ostium secundum, then there is septum secundum.
Oh, I'm so sorry. It's septum secundum I'm talking about. I'm trying to say that the septum secundum comes from the roof. Okay, you are saying ostium secundum is at the bottom.
No, I'm saying that septum secundum comes from the floor towards the roof.
No, it comes from the roof to the floor. Sorry, I was mixing up the names, ostium and septum.
Septum secundum comes from the roof.
Yeah.
But it doesn't get to the endocardial. It doesn't get to the endocardial cushion. So one of them is crescent shaped, one is sickle cell shaped. The septum secundum is the one that moves to cover. The septum premium is rigid. So the septum premium comes at day 33. The septum secundum comes at day 40. So as the septum premium is coming down, as it gets to the endocardial cushion, there's a small part towards the superior part. It's like a apoptosis. It becomes a small hole. Then 7 days later, the septum secundum starts coming down, but never ever gets to the endocardial cushion. Then they now have a space where you now have a patent foramen ovale.
Okay.
And that should close in a couple of days after delivery. So so if the case as the septum secundum is the mobile one, the septum premium never moves.
Okay. Thank you so much.
Okay, so we'll move to question
Sorry,
6.
but frankly, when I saw that question, what came to my mind as the answer was patent foramen ovale. But I guess they said defect, and we know that fossa ovale is not a defect, so probably that's why it's a secondum ASD. So, well, thank you. So I think we can go on now.
Okay, so question 6 says, which congenital heart disease is detected by auscultating over the spine? So that must be a problem that is located towards the back. So we look at atrial septal defects. No, that's in the front. Coarctation of the aorta. Once it's towards the descending part, towards the second half of the arc of the aorta towards the descending part, that's forced towards the back. So that is most likely. Then double orifice mitral valve, that is not in the back, it's in the front. Patent ductal sartorius is in the front. Ventricular septal defects also in the front. So correct option is coarctation of the aorta. Hello? I think that's a bit straightforward. So I'm moving to question 7.
Okay, I believe that should be that Edward sign, right? The sign that you get when you auscultate over the spine, near the
Over the spine.
near the interscapular area, isn't it?
Okay.
I think Ewasali is seen in Camponato. Top percussion.
Hello.
Yeah, it's in tamponade.
It's in tamponade.
Okay.
Cardiac tamponade.
Oh, okay.
You have no percussion note.
I
The
thought
level-
it was
Yes.
seen. Sorry.
Yes.
I thought Edward sign is seen on the left lower lung, a bronchial breath sound that is seen
A bronchial
because of
breath sound in the upper part
pericardial
of
effusion.
effusion, yes.
Oh, okay.
Pericardial effusion.
That's
That's
done
Edward
next
sign.
to percussion towards the lower part. Why there's
Left
bronchial breath
lower,
sound on the upper part.
yes,
Yes.
bronchial breath sound seen in
Okay.
pericardial effusion.
Okay, thank you.
Oh. So question 7. Yes. But are you saying anything?
No. Sorry, sir.
Sorry, just wanted to mention that the Edward sign is actually head at the back. Is it head in front or at the back? Because I'm seeing here that head at the back, though it's in pericardial effusion.
It's head at the back.
At the back. Okay, thank you.
Back.
Posteriorly.
Okay.
But Dr. T. Adeanju is saying Edward sign is in cardiac tamponade. Dr. T, do you have support for your argument?
Yes, it's cardiac tamponade. I've seen it here too. It's also known as pin sign.
Okay.
Hello, which one? Ewart sign?
Yes, Edward sign.
No, Ewart sign is not tamponade. Ewart sign, you see it when you have a large pericardial effusion.
Oh,
And it is
okay.
not always that a large pericardial effusion will give you tamponade. Tamponade mainly is driven by the rate of accumulation of the fluid and whether the pressures have increased to overcome the intrapericardial pressure. So EWAT sign is for a large, when you have a large pericardial effusion, it's like it squash a portion of the lung, and then you get that area where you hear the crepitation.
Okay, thank you.
Yeah.
Any more contribution? Okay, so I'm moving to questions.
I used to think that if you want to get our society on precaution, you don't not actually on our spot. So because of the large common thing, how much people go?
Sorry, I can barely hear the speaker.
Hearing you. You are very distant.
Copy,
As if you have pericardial tamponade, pericardial effusion, sorry.
Hello.
Yes,
we can hear you now.
My speaker has a problem.
All right. I beg, in line with all these ewa beings, everything sign. Let me call out some signs of pericardial effusion, please. There's the Peter sign. The Peter sign is the anterior bulging of the lower sternum, which suggests pericardial effusion. And then there's the Hallbrugger signs, which is protrusion of the epigastrium, suggesting massive pericardial effusion. Before Prof will now bring Peter's sign.
Post it on the platform. Let's see. Let's speak it because
it's just signs of pericardial effusion. If you type signs of pericardial effusion,
yeah, just post it for us to see.
I just make I check signs of pericardial effusion. So I'm just seeing new signs, brother. This country. All right, let me post it. We can hit the ground.
Okay, so question 7 says, in which of these congenital heart disease is unoperated adult survivor exceptional? That's unusual to have an adult survivor. So bicuspid aortic valve, a lot of people have that. Coarctation of the aorta, somebody can have that at adults. Pulmonary stenosis, yes, it can occur at adults. Patent ductus arteriosus can also occur at adults. But large VSD, survivor to adulthood is actually very slim. So the correct option would be E.
Please go ahead. It's clear.
Well, if that is taken, I think my portion is 1 to 7.
Sorry,
No,
I
it's
did
1
not
to
get
10.
your answer. Your line break a little bit when you are giving the answer.
No, I was saying that looking at the way the question was framed, in which of these congenital heart disease is unoperated adult survivor exceptional? That is, adult survivor is unusual. So we want to see which of these options do you find an unusual survivor of an adult. So bicuspid aortic valve, that you can find in adults easily. Coarctation of the aorta, you can find that in adults. Pulmonary stenosis, you can find that in adults. Patent ductal arteriosus can also be in adult. Large VSD, they rarely survive to adulthood.
Sorry, can
So
you
that's why,
remind us again of the definition of life VSD again, the size? I thought we have gone to it. The definition of large VSD based on the
I don't have the figure, honestly.
Okay, if anyone has it,
I
can
don't have the figure.
okay, maybe someone can help us. Someone that knows, I beg.
You can check that later and get back to you. If there's nobody here that knows it, please. Can we check it up?
Okay. I'll try and check it.
Let's take time and check it and see.
Thank you. Let me
So
also
we
check.
call on our beloved Dr. Tia Deanju to take the next set of questions since we don't have the other two ladies on ground. Mr. Deanju, please.
I can see somewhere they say large VSD, 6 to 10 mm in diameter.
Okay. Thank you.
All right.
Adeanju. Dr. Adeanju.
Sorry, I'm here. Sorry.
All right,
So
over
sorry.
to you.
Yeah, good evening, everyone. I'm sorry, I'm trying to do my work, but I will read through, and I hope that the class will also assist me because I was not able to prepare for it. Okay, we can put together, I guess.
All right. So
Thank you.
Let's hit the ground running.
Question 8. Generally, congenital heart disease is more common in males, but some types are specifically more common in females. In which of the following are males more represented? Patent ductus arteriosus, that's option A. Option B, Epstein anomaly of the tricuspid valve. Option C, atrial septal defect. Option D, aortic valve stenosis. If I can recollect very well, I think PDA is in females. Epstein anomaly, I'm not very sure. I think ASD is in males. Aortic valve stenosis, I'm not also very sure. So I'm not sure of the right answer here, but maybe it's possibly C. I don't know. Professor Hasu, I think you are the congenital heart professor. Can you kindly help out?
Dr. Ayodeji.
Okay.
Ayodeji. Ayodeji is not around though.
Okay.
Okay, so PDA
I don't have
and
that.
ASD are actually one of the ones that are actually more common in females. The PDA and ASD, they are one of the more common ones in females. The other ones are either there is no sex predilection or they are more common in males. So, for instance, coarctation of the aorta and the others are mostly common in males. So, and then looking at these options now, PDA, yes, is more common in females. Then Epstein's anomaly, what I have is that there's no sex predilection for it. Then ASD is more common in females, and then aortic stenosis is more common in males.
Okay.
Yes, aortic valve stenosis. Yes.
So that means the answer here is option D.
Yes, option D.
All right, thank you.
Thank you.
Yes, D.
You're welcome.
So the option here, the right option here is option D. Dr. Kopi, can we move to the next question, please?
Yes, please. So please hit the ground running.
Thank you. So question 9, when a child is born with abnormalities in the head and neck region, together with a cardiac malfunction like PDA, which of the following may have happened to the mother in pregnancy? Okay. Abnormalities in the head and neck, PDA. Okay. Option A, rubella infection. Dr. Okope, we can't hear you. Option B, Sir, your network is still unstable. Option B, thalidomide ingestion. I think that one is common. We say Amelia, those are limb malformation for thalidomide injection. I can't see the question again, but I can remember that there is. Okay, I can remember that there's alcohol abuse there, and we can have this fetal alcohol syndrome. In which the child will be floppy, and then they will have some microcephaly and some other mental retardation and some other things. I can't remember the other options there. Maybe we'll wait for Dr. Opoki to come back. But I don't know, can anybody remember rubella infection in pregnancy? And all I can remember is that they can have, I think, abortion. Then I think they've talked about some cardiomyopathies. I can't remember very well, but I don't know if anybody can remember rubella and pregnancy. While we wait for Dr. Opoki to come back. Welcome back, Dr. Opoki.
Let's check it.
Okay, so rubella infection can actually be associated with that's a rubella infection in pregnancy may actually be associated with certain congenital heart diseases like a PDA, pulmonary stenosis, ASD. Additionally, other non-cardiac complications may also come in, like cataracts, and they may have retinopathies and microcephaly. So for thalidomide ingestion is actually associated with phocomelia. PDAs as well, from what I saw, PDAs may also occur, and then Epstein anomaly. So I don't know. Epstein anomaly may happen with thalidomide, phocomelia, and PDA. Then for lithium, Epstein anomaly is usually associated with lithium ingestion. Then alcohol abuse, apart from the fetal alcohol syndrome, they may also have endocardial occlusion defects. And I also came across TOF. Yes. Then for the systemic lupus erythematosus, usually it may not cause like a visible cardiac, like a structural abnormality, but for mothers that have this anti-LA and anti-Rho factor, it increases the risk of a congenital heart block in the fetus or the baby that is born from them. So those are the things I have. Maybe we could still check to confirm, but
so you didn't find anything with lithium and the abnormalities in the head and neck?
I didn't look for it. I think I was focused on the heart, but I think it does have.
Thank you very much. So that means with the help, that means that the correct option here is between A and B.
Okay, but what makes this one different, I think, is the fact that, like Dr. Kopi said, the head and neck region, yes, together with the cardiac malfunction. So, and we know that what they call it, rubella could cause microcephaly, could cause meningoencephalopathy as well. So that should make it the most appropriate amongst these ones.
Thank you very much. So the correct option here is option A.
Yes.
This is the option. Okay, we move to the next question. Which of the following cardiovascular and non-cardiovascular manifestations are correctly matched for Apert syndrome? What's Apert syndrome? again. I can't fully recollect what Apert syndrome is.
Let's check. We can check it online now. What's Apert syndrome? I remember, but I can't get it clearly now.
Okay, thank you very much, Dr. Okope. So I will just read the option: single atrium and chondrodystrophic dwarfism, atrial septal defects, and skeletal upper limb defects, pulmonic valve dysplasia and web neck, pulmonary stenosis and broad fasciae, ventricular septal and syndactyly. Well, I'm lost. I don't know. I can't recollect Apert syndrome. Let me check.
It's even in Medscape. So Apert syndrome, cardiovascular characteristics include atrial septal defect, patent ductus arteriosus, pulmonary stenosis, overriding aorta, coarctation of the aorta, dextrocardia, tetralogy of Fallot, endocardial fibroelastosis.
Sorry, Dr. Okope, can you come again, please? Thank you.
Okay, but let me just give what the definition of this Apert syndrome is all about. It's a rare autosomal dominant disorder that is characterized by craniosynostosis, craniofacial anomalies, and severe symmetrical syndactyly. It has cutaneous and bony fusion of the head and feet. It is probably the most familiar and best described type of acroencephalosyndactyly. So the syndrome was named after the French physician who left his house and went and discovered something that we're not supposed to know. Apart. So
okay. Thank
basically,
you. Okay.
it's fusion of the skull and the limbs. All right.
Thank you very much. But please, professors in the house, looking at the question again, with what has been read by Chief Okope, still at sea, because I really don't know what they want us to match now. The following major cardiovascular and non-cardiovascular manifestations are correctly matched for Apert syndrome. With what Dr. Okope have read, he mentioned cranial.
The hallmark is syndactyly.
Yes, but then
Yes.
is it with PhD?
Yes, I read out the cardiovascular manifestations first. The cardiovascular association of Apert syndrome. There is atrial septal defect, ventricular septal defect, PDA, overriding aorta, coarctation of the aorta, and tetralogy of Fallot. So there's PDA, ASD, VSD, pulmonary stenosis. Almost every part of the heart, both the outflow tract and the septum, they are all affected, together with tetralogy of Fallot and dextrocardia. So if you look at this, the hallmark is syndactyly, and there's VSD. So that should be E. They don't have this broad.
But what about the atrial septal defect and the skeletal upper limb defect?
Is it really a skeletal, just upper limb defect? Yeah. It says characterized by craniosynostosis, craniofacial anomalies, and severe symmetrical syndactyly of the hand and feet.
Okay. Thank you very much. So the correct option here is E. Oh, please, I don't know whether there are any other contributions. Okay. Please, is that the question at the back too?
Yeah, so Prof chose question 10. E.
Okay, so question 11. Which of the following TU disorder will result in isolated aortic incompetence? I'm so sorry, I didn't prepare for this class. Which of the following TU isolated aortic incompetence? Okay, option A, Otis-Laxer. Option B, Ehlers-Danlos syndrome. Option C, Marfan syndrome. D, osteogenesis imperfecta. I think it's supposed to be imperfecta. Option E, pseudoxanthoma elasticum. The result in, said, I can remember that Marfan's, Ehlers-Danlos, osteogenesis imperfecta, and possibly option aortic affectation. But what I can't remember is whether they are isolated or not. So please, class, I also need help with this question. Excellent. Sorry, please, I need help.
Hello, we'll have to check it. We have to check each of them. But I know that I read yesterday some of these isolated connective tissue stuff. Ehlers-Danlos, definitely not. It has both the mitral incompetence, mitral valve flora, propellers, especially the posterior mitral valve. Not Marfan's. We all know Marfan's will have. Let's check.
Good evening.
Everyone, please go ahead.
Have you found the answer 11?
Oh, please, we're waiting for you to help us out.
I'm reading Oxford Handbook of Cardiology under God, and they say one of the causes, other causes of rare, that is, other causes of aortic regurgitation are osteogenesis imperfecta. Then they mention syphilis, hepatitis, spondyloarthritis. So I think the answer is osteogenesis.
What you read, you are talking of rare causes, but I think what Prof's question is saying is isolated. So I'm not sure if they translate to mean the same.
Okay, isolated. That's all they have.
You said what you read is rare causes.
Rare causes of traumatic regard, yes. Yes. Okay. Okay.
Dr. Zakia said she's been trying to connect. Her network is logging her off, that she has prepared for these questions. So I just told her to try and look for a better network and connect. Maybe she can help us out. So we're chatting at the back end. Meanwhile, we can do a Google search for this, please.
I wish Dr. Okopi, you can share your network with her.
This is my network. Can only share it. I can only share it with Conte. Only between and Conte that this network can work. It can't work any other place. If I share this network with any one of you, it's over. This year will pass the judgment. All right, let's do network check, please. I mean, Google search. Prof.
Hello. So I tried to search, and what I saw was Marfan syndrome. However, I'm still searching. What I saw was Marfan's, but I'm still searching.
This question cannot defy the minds of over 24 top-notch, highly cerebral, hotly baked cardiologists on this forum. I put it to all of you that you guys are better than these questions. So let's hit it and hit it hard.
Dr. Okopi, I was about to think whether if we can continue while I study on it and take it again, or if Zakaria is able to join or something, so that I won't just keep all the class. But what's Prof answer at the back?
His answer is D.
D, osteogenesis imperfect.
I think it has to
Let
do
me
with
ask a
the
question.
type of collagen they have, or the collagen defects they have, but just not.
It requires a lot of studying because all the other options too will have collagen defects, I should think. Yeah.
Question, what do we think he means by isolated aortic insufficiency? Is it that there's just aortic insufficiency that is as a result of maybe a problem with the aortic valves, or there is aortic insufficiency with aortic root dilation? Because most of those other syndromes, from something I'm looking at here, although it's just a table, will give you dilation of the aortic root. Okay, that's Marfan's, Ehlers-Danlos, osteogenesis imperfecta. They will all dilate the aortic root. There's a table I'm looking at here that is saying that. But pseudoxanthoma elasticum will just give you aortic valve disease without dilating the aortic root. Then that option A, that cutis, I didn't see it, is not here. Cutis nadals. Cutis nada is not here. So I don't know. But from what there's a table here is up to date that is saying that all these other ones will give you aortic root dilation. So I think aortic root dilation is the means, like in Marfan's, is the dilation that gives you the aortic insufficiency. Okay, same with Ehlers-Danlos and osteogenesis imperfecta. But in pseudoxanthoma elasticum, the problem is from the aortic valve, not from the root. Okay, but I don't know. That's something, that's an angle we can look at if we have not looked at it.
I received a call. I was talking with Dr. Zakia on the call. Have we answered it, please?
Well, not really. We are still trying to look at the question from the angle.
Prof book says it is osteogenesis imperfecta. Probably we'll research it so that we don't stay too long on that question. While we are researching it, somebody can call our attention to it as we move forward so that we don't stay too long and run around. But meanwhile, please, let's be doing search while we're going forward.
Okay.
So I think we'll have to go forward. All right, question 12. But the book says it's osteogenesis imperfecta. So in case we want to take it and cram it and later search it out, please let's do. So question 12.
Septum is made of 4 compartments. In which compartment is most of the ventricular septal defect seen? A, membranous septum, B, inlet septum, C, trabecular septum, D, inlet septum, and E, infundibulum septum. I think it's mostly in the membranous septum, but then I don't know whether there are any other contribution. But what's Prof answer at the back? I think most of them are in the membranous septum.
Yeah, you're right.
Yeah. Okay.
What is the percentage?
Oh,
do you have?
I don't have that.
Dr. Ayodeji.
80%, 80%.
You say what?
About 80%.
80%, okay.
Yeah.
Thank you so much.
The muscular, that's the trabecular, is 5 to 20%. The muscular also called the trabecular. And that's where you see the switch septum, or 5 to 20%.
Okay.
All right. What about
Thank
the, thank you.
Inlets said about 8 to 10.
8 to 10.
Yeah.
Infundibulum.
And that's the supracrystal.
And that's supracrystal.
Let me check that one.
All right, so thank you so much. So it's A, which is 80%. So let's keep going while he search it out. So question 13.
Okay, so question 13. Which of the following congenital heart disease? Sorry, Dr. Okupe, I didn't hear you.
Okay, so you can hit the ground running. Hit the ground.
Okay, we are eating it. Thank you. Which of the following congenital heart diseases result when there is failure of resorption of the common pulmonary vein? Okay. Option A, congenital aortic regurgitation. Option B, pulmonary vein atresia and stenosis. Option C, cold triatrium. Option D, congenital mitral stenosis. Option E, congenital mitral regurgitation. Okay. I think that the correct answer here is option C.
Yes, even myself.
Or is it
But
guess?
and Dr. Deji. The professor of the U wave of the ECG. Ayodeji, do you have any
Actually,
more
the
to add?
correct answer.
All right, let's hear.
For that one.
All right, thank you.
Okay. Why is it sorry that I'm asking that why is it the correct answer?
Okay, so cold triatrium is actually a defect that more like will I call it an abnormality that occurs when there's an incomplete resorption of the common pulmonary vein. That's what results in a cold triatrium. So it forms like an appendage that divides the left atrium into two chambers.
Okay. Thank you very much. So question 14. Dr. Opopi's screen is saying screen sharing, so I can't really see it well. Okay, yes. Mitral valve disease could be congenital or acquired. When the valve is stenosed congenitally, which of the following structural abnormalities will result in it being described as benign parachute deformity? When the valve is stenosed congenitally, which of the following structural abnormalities will result in it being described as benign parachute deformity? Okay, I think it's Professor Jacqueline that will answer this question. She sent a picture to the main group before. So option A.
I don't have the answer. Well,
okay.
What is Barlow syndrome?
Okay, let me just continue. Option with convergence and insertion. Chordae are shortened with convergence and insertion into a single large papillary muscle. Option B, leaflets are thickened with shortening and fusion of chordae tendineae. Option C, there is an anomalous arcade of obstructing papillary muscles. Option D, there is an accessory mitral valve tissue. Option E, there is a supravalvular circumferential ridge of connective tissue at the base of the atrial aspect of the mitral leaflet. Okay, so I don't think it's option C. I don't think it's option D. Option A, there's a supravalvular circumferential.
Yeah, I think you're right. That describes option A, or the parachute syndrome. So
okay,
it's when all the chordae insert into one papillary muscle. Okay. Like you have one man dangling down a parachute. All the cords come to one person dangling down the parachute. That's basically the description.
Oh, thank you very much, Dr. Sarah Conte. Okay, so the correct option here is A.
The name is not sorry.
Okay. So Conte, please, what's the name? What's the correct pronunciation of your name, please?
Sorry. It's one R, so it's sorry.
Sorry. Okay.
Sorry.
Yes.
So, all right. Thank you very much. Say apologies. Okay, so the correct option here is A. Which of these
before you answer question 15, you have to inform the other crew members that you want to land the plane.
The other crew members have been of immense help. because I didn't prepare for this. So question 15, which of these congenital oh, this is the last question. Oh, I get you. Which of these congenital heart disease is seen in adults with expected unoperated adult survival? Is least common. Sorry, let me go through that again. Which of these congenital heart diseases seen in adults with expected unoperated adult survival is least common in occurrence? Why did Prof set this question this way? It would have been smoother.
The English is a challenge.
We will unravel it.
So which of these congenital heart diseases is seen in adults with expected unoperated adult survival?
Yes. So what he's asking is that there's a congenital heart disease that, you know, that if it's not operated, they survive into adulthood. But which of the following option is least?
Okay.
I
Bicuspid
think just
aortic.
like the one I did, that's what they mean, I think.
Bicuspid
That the
aortic.
one that their survivor is difficult to the adulthood.
No, I think that it's saying that
Survivor is into the adulthood, but which among these is least in occurrence?
The list, yes.
So that means that you expect that they will survive into adulthood. Those group of people with but which one of these options without being operated?
They can survive.
But the one that can have a worse or the list of such.
No, the one. Which one is least in occurrence amongst these that can survive into adulthood, if not operated?
Yes,
unoperated, all of these can survive into adulthood, but which of them is the least in occurrence?
List, yes.
Okay. All right. Option A, bicuspid aortic valve. Option B, fracture of the aorta. Option C, pulmonary valve stenosis. Option D, ostium secundum atrial septal defect. Option E, situs inversus with dextrocardia. So option E, D, and A will definitely survive to adulthood. I mean, we'll have a higher percentage. So I think the answer is between fracture of the aorta and pulmonary valve stenosis. I think I may be going.
We are getting the interpretation, as in Dr. Adeyandra. I think you've mixed up the interpretation, sort of.
Okay.
Because what it's telling us is that these congenital heart diseases are expected to, as in you're expected that if you see it in someone, the person will likely survive into adulthood. But amongst all of them, which of them has the least prevalence?
Yes, that's what we
Oh, okay. I thought you're
survivor.
saying that. Oh, okay.
That's what we are trying to answer here.
Okay.
That's something that happens between B and C, and I think pulmonary valve stenosis might be the correct answer, but I am not sure.
For me, I think they are saying which one has a worse of outcome.
No. I think they are saying that just what Princess Jacqueline said now. I think they are saying that all of them will survive into adulthood, but in looking at prevalence, what's their percentages of survival to adulthood? Maybe looking at it the other way, so maybe what you also said now is also correct. I mean, we see secundum atrial septal defect, which I think will be the highest percentage here. Well, I think we see a lot of that.
Yeah. Or bicuspid aortic valve.
Yes, I think we see them too. Situs inversus with dextrocardia, we see them without being operated, they survive into adulthood. But fracture of the aorta, they survive to adulthood, but I don't know the percentage, depending on the degree and the different level of fracture of the aorta. But pulmonary valve stenosis, and by the time you are seeing them, they have secondary complications when they come in, when they present in adulthood. So that's why I'm thinking that the option will be between B and C, but I need help.
What about E?
How common is the situs inversus with dextrocardia when you look at it compared to the others?
Okay, well, that's something to consider. So, well, in my short time of learning, of being a student, maybe I've seen just 3 or 4 thereabouts. So maybe they are not really as common as I'm thinking.
Was it dextrocardia with situs inversus or dextrocardia with situs solitus you came across?
Okay, one was with situs solitus. I think 2 were inversus, if I remember correctly. But the most recent one I saw was with solitus.
Okay, the ones I've come across are actually only those with solitus. I've not come across situs inversus before now.
Okay.
Because Prof chose E.
Oh, great. Dr. Pope, I think you are the one that will land this ship. So please come forward and land it in a big way.
All right, thank you, ladies and gentlemen, for a very smooth ride. You can all agree with me that we had a very nice time. I hope we enjoy the next flight we'll be taking. Maybe a little bit bumpy. We'll be cruising at 50,000 feet above sea level. The pressure will be okay, so don't worry. 50,000. It's all right. And we're going to be using a propeller, so relax. So thank you very much, everyone. We've come to the end of this prep pool. If you need any further clarification, you can reach out to us at any time. But for now, we'll assume that we all understood what we went through. We'll start the recall MCQ by Monday. So we have Dr. Charles Okorie to take us on the presentation. Dr. Charles, the floor is to you now. You can share your slide.
Okay, good evening, everybody. Let me share my slides. Princess.
Dr. Charles.
Yes, I'm with you. Just give me a minute.
Dr. Ahmed. Alex Itubi.
Present, sir.
Make me co-host, please.
Oh, it's happened again. Sorry.
Oh, please be present because Charles will discuss something very.
All right, can you see my slide, please?
Yes, please. You have approximately 2 hours to put. We'll use 30 minutes.
2 hours. I will use up to 2 hours. It's not up to a 2-hour presentation. It's like a 40 minutes presentation.
2 hours.
No, it's not. All right, good evening, everybody. Taking the topic, peripartum cardiomyopathy. These are outlined. By way of introduction, like we all know, it's also called pregnancy-associated cardiomyopathy. Peripartum cardiomyopathy is a rare cause of heart failure that affects women either late in pregnancy or early in the puerperium. Okay, it was initially described in 1849, but it was not recognized as a distinct clinical entity until the 1930s. It has been severally named by different people, and such names include things like toxic postpartum heart failure, Meadows syndrome, Zaria syndrome, of course, we know that it's common. It's very common in northern Nigeria, or it's more common in northern Nigeria. And postpartum myocardiosis. Okay, now to define peripartum cardiomyopathy adequately, you must have all three of the following. Okay, number one, there must be a development of heart failure in the last month of pregnancy, that's towards the end of pregnancy, or within 5 months following delivery. Okay, then it's a diagnosis of exclusion, so there will be absence of another identifiable cause for the heart failure. Then the third one is that there will be left ventricular systolic dysfunction. The definition of LV systolic dysfunction in peripartum cardiomyopathy is an ejection fraction of less than 45%. Now, this, like the definition of dilated cardiomyopathy, can occur with or without left ventricular dilation, although in most cases, you will see it with LV dilation. Okay, the epidemiology is a global, of course, there are differences in incidence all over the world. Okay, with the highest incidence being in Nigeria, in Zaria, where it's seen in about 1 in 100 women, then the lowest being in Japan, where it's seen in about 1 in 20,000 women, or 1 in 20,000 births, if you want to put it that way. Okay, of course, there's widespread geographical variabilities, commoner in blacks. There's also a high genetic predisposition to the development of peripartum cardiomyopathy. It said that the incidence is increasing, although the reasons for that could be that maybe it has always been there, but we're having, with improvements in healthcare, we're able to diagnose it quicker. Okay, then also with, of course, one of the risk factors is increasing maternal age. So with the advancement of reproductive techniques, more older women are becoming pregnant. Okay, so those are other things. Then preeclampsia, all these other risk factors for PPCM are increasing, multiparity, multiple gestations, and other maternal cardiovascular risk factors. Okay, the mean age, although peripartum cardiomyopathy can occur in first-time pregnancies, okay, but the mean parity of women who have PPCM is about 3, and the mean age of presentation is said to be 31 years. Okay, the risk factors include age greater than 30 years, women of African descent, pregnancy with multiple gestation, okay, twin, triplet pregnancies, previous or current preeclampsia, eclampsia, or postpartum hypertension, use of cocaine in the mother, long-term oral tocolytic therapy. So for women who have used the tocolytics like tebutalin, is also a risk factor, maybe to delay the occurrence of labor. Then a high parity, more than 4. Okay, what's the pathogenesis, or what are the pathogenic factors responsible for the development of peripartum cardiomyopathy? There are several, of course, all these things are the cause, like most things in medicine, is actually unknown. So all these are speculations and contributory factors, okay? He said that there could be an androgenic imbalance, okay? Data from research suggests that peripartum cardiomyopathy may be caused by a lack of the peroxisome proliferator activated receptor, gamma coactivator, that's the one they call PGC. 1 alpha. Okay, this molecule is said to be a key regulator of pro-angiogenic vascular endothelial growth factor. Okay, so this is one of the postulations, actually, that there is imbalance in angiogenesis. Okay, the second one is it said that it's been noted that patients with peripartum cardiomyopathy have altered processing of prolactin. Okay, so this comes to importance when we're talking about treatment of peripartum cardiomyopathy, where we see that bromocriptine is now being used, although it's not officially approved. Bromocriptine is one of the things that can now be used for the treatment, and it has been shown to improve ejection fraction and and outcome and general outcome in patients who have peripartum cardiomyopathy. Okay, there are also other pregnancy-related hemodynamic changes. Okay, like we know, normal pregnancy is a cardiovascular stress. Normal pregnancy is a cardiovascular stress, and such that uncomplicated pregnancy is said to be similar to completing a normal stress test. Okay, and of course, this stress is usually most pronounced towards the end of the pregnancy, during delivery, and in early postpartum. Okay, of course, the changes in the woman that occurs during pregnancy include an increased LV volume, there's increase in LV mass, increase in circulating blood volume. They also have dilutional anemia, and there is sometimes shunting of up to 25% of the circulating blood to the fetus and the placenta. Now, it said that women who are now genetically susceptible to, because the issue has been actually differentiating peripartum cardiomyopathy with the baseline or idiopathic or familial dilated cardiomyopathy. So in some of these patients who have genetic susceptibilities, the stress of the pregnancy may now tip them over, and this tipping over will now occur towards the end of the pregnancy or in the early purpurium, okay, because that is when there's said to be more marked cardiovascular stress. Okay, now let's talk about genetic predisposition. Okay, now there has been some associated mutations that tend to cluster in families. Some of these mutations have been associated with both peripartum cardiomyopathy and the familial, or the one we call the idiopathic dilated cardiomyopathy. Okay, so some of these genes, that the most important gene actually that they talked about is the one called, or this is called, is a sarcomeric protein called titin. Okay, it's called titin. So abnormalities in this, or the expression of this, or abnormalities in the gene expression of this protein is known to be associated with dilated cardiomyopathy. Okay, in patients who develop PPCM, the presence of titin, those who develop PPCM that are titin positive tend not to recover, okay, unlike the other ones that will likely do very well. Okay. Now, studies have also shown that individuals who have a family history of dilated cardiomyopathy, sister, father, close family history of anybody with dilated cardiomyopathy, also tend to have poorer recovery rate. So this tends to suggest that these patients will have, although they are presenting for the first time in pregnancy or purpurium, they may actually have the idiopathic or the familial dilated cardiomyopathy. Other immunologic factors, other things involved in the pathogenesis include immunologic factors, inflammatory cytokines. Okay, cytokines that are elevated include tumor necrosis factor alpha and interleukin 6. TNF alpha and interleukin 6 have been said to be expressed in high levels. So they have actually, since there's interleukin, TNF alpha and interleukin 6, research has tried to show whether immunosuppressive therapy, either using steroids, biologics, or the other ones would have helped, but it has not been shown to help. Okay, in peripartum, or so far it has not been shown to help in peripartum cardiomyopathy. Okay, then other molecules like FAS or APO1 and C-reactive protein, when seen in patients with peripartum cardiomyopathy, have been noted to be associated with more severe disease. Okay, then people with peripartum cardiomyopathy are also known to have higher levels of autoantibodies. For example, antibodies to cardiac myosin, to adenine nucleotide translocator, and branch-chain alpha keto acid dehydrogenase. They have been shown to have antibodies to these molecules. Yeah, they have higher levels when compared with controls. Then infectious factors. Infectious factors include Infectious and environmental factors include things like myocarditis. Of course, the role for myocarditis is uncertain. Okay, but some studies where they have done endomyocardial biopsies have seen more myocarditis in patients who develop peripartum cardiomyopathy. Of course, but this is still not yet proven. It's still neither here nor there, but it's one of the possible things that may contribute. Okay, we'll talk about the clinical features. Of course, I won't talk about this much because clinical features, they will usually present like typical dilated cardiomyopathy in heart failure. Okay, so the things that we'll talk about are the things that are specific to this illness, because if not, they will present the way others will present, just that they will either be pregnant or they would have just delivered. Okay, when it comes to the timing, peripartum cardiomyopathy is less common. You remember the definition. It's less common before 36 weeks of gestation. Usually presents either that or the most common presentation is actually within the first month postpartum. Okay, but it's said that there's no significant difference for those who present in pregnancy or those who present there's no significant difference in mortality actually for those who present in pregnancy or those who present in puerperium. Okay, now one thing that is very important with peripartum cardiomyopathy is to know that unlike other cardiac diseases in pregnancy, of course we know a whole lot of cardiac diseases can present in pregnancy for the first time. Congenital heart disease, whether it's VSD, ESD, can actually present in pregnancy for the first time. Valvular heart disease, aortic stenosis, mitral stenosis, whatever it is, can actually present in pregnancy for the first time. Or even intrinsic cardiac muscular disease, that's the familial dilated cardiomyopathy or hypertrophic cardiomyopathy, whatever it is, restrictive cardiomyopathy, possibly can also still present in pregnancy for the first time. But the difference between this is that for all those other cardiac diseases who are presenting in pregnancy for the first time, they will usually tend to present earlier. Okay, they present most likely in the second trimester when the burden produced by the increasing uterus is also they usually present in the second trimester, unlike peripartum cardiomyopathy that will present towards the end or in the early puerperium. Okay, what would they present with? Of course, they'll present with symptoms typical of heart failure, okay, of systolic heart failure, okay, which, like we know, dyspnea on exertion, progressing to dyspnea at rest, autopnea, progression of dyspnea. They present with features of fluid accumulation, pedal edema, and all that. If there is pulmonary edema, they can have hemoptysis. Okay, so the way heart failure will present is the same way they will actually present. Okay, and in the initial time, these symptoms are usually non-specific because a lot of pregnant women do have pedal edema. A lot of pregnant women do have easy fatigability. So if the symptoms are not that marked, it may just be attributed to the stress of pregnancy, although they will likely be more pronounced in patients that have peripartum cardiomyopathy. Of course, the signs will be signs of heart failure. So they will have elevated JVP, displaced apex. They may have a third heart sound. Of course, with annular dilation of the mitral valve root, you have mitral regurgitation, and they may have a polysystolic murmur of mitral regurgitation. Okay, then another thing that is important to note that they may have signs and symptoms of systemic or pulmonary thromboembolism, depending on if such has occurred. Okay, like I said, definition is what you use to diagnose peripartum cardiomyopathy. So they develop heart failure towards the end of pregnancy or in the months following delivery. There's no other identifiable cause. You see, you do echo, there's no valve disease, there's no congenital heart disease, and there's what looks like a dilated cardiomyopathy. Then they have LV systolic dysfunction. This is a must with an ejection fraction less than 45%. Okay, so when you have this patient and you suspect, you go ahead to investigate. Of course, you do the usual investigations you usually do. Just like heart failure, ECG is actually non-specific. You will not likely, but it's unlikely that you will see a normal ECG, although the findings you may see in the ECG will be highly non-specific. but a normal ECG does not exclude peripartum cardiomyopathy as a cause of patient symptoms. What are the common things you may have? Sinus tachycardia. Yeah, they may have a dilated left atrium and presenting atrial fibrillation. They may have non-specific ST and T wave changes. They may have anterior Q waves possible, prolonged PR interval. They may even have a widened QRS duration. Okay, of course. All right. So after echo, of course, echo is one of the first things you should do evaluating anybody that comes with heart failure. So echo should be done in all patients whom the diagnosis of peripartum cardiomyopathy is being considered. What you see is a reduced left ventricular systolic function, ejection fraction, always less than 45%. The LV is usually dilated. Of course, like we said, LV dilation is not a must, but most times you find that the LV is dilated. Okay, then of course you can do Doppler to assess right ventricular systolic pressures, and you can check tricuspid regurgitation and all that. So with this, right heart catheterization will not likely be necessary for most patients. Other things you see in echo, a left atrial enlargement is quite common. You may see a thrombus in the left ventricle or in the left atrium. Okay, it's also quite common. Of course, they have hypokinesis of the LV free wall, stasis and all that to promote clot formation. If there's pulmonary hypertension, you may have a dilated right ventricle with right ventricular hypokinesis. You have mitral and tricuspid regurgitation, and most times you can also have a small pericardial effusion. Okay, so this is an echo picture of this apical fourth chamber. Of course, this is how classical peripartum cardiomyopathy looks. Dilated left ventricle, dilated right ventricle. In fact, dilated all chambers, both to left atrium, right atrium, left ventricle and right ventricle are all they are all dilated. The picture on the right shows where you have mitral regurgitation from annular dilation. Okay, so this is classical echo, apical fourth chamber for peripartum cardiomyopathy. Okay, so this one it tries to show the apical thrombus. Okay, there may be a thrombus in the apex of the left ventricle. Otherwise, it's more of the same in the previous picture. Okay, chest X-ray.
Dr. Child, is there a fan running at the background?
Yes, it is. Let me put it up. I don't really need it.
Okay. Thank you.
Okay, sorry about that.
No problem, sir. All right.
So chest X-ray. Chest X-ray is not necessary to make a diagnosis of peripartum cardiomyopathy. And of course, if the patient is pregnant, chest X-ray will expose the baby to ionizing radiation, so which is a major drawback. Okay, but if the diagnosis of pulmonary edema is not sure clinically, of course, you can make the diagnosis with history and physical examination. But if it's not certain, chest X-ray can be considered, but of course, you must do a lead shield or abdominal lead shield or fetal lead shield to protect the unborn child if the patient is pregnant from ionizing radiation. Chest X-ray will show the typical things in heart failure: enlarged cardiac silhouette, alveolar edema, facial edema, Kelly B lines, pleural effusion. Okay. Then, of course, brain BMP and end-terminal pro-BMP. This, of course, like we know, is very important in diagnosis of heart failure. Okay, women presenting with peripartum cardiomyopathy will typically have elevated BMP that are higher than those seen in healthy women with pregnancy or postpartum. It's important we know that BMP is raised in pregnancy. In fact, they said it's up to 2 to 3 times the upper limit of normal in pregnancy. Okay, so but in heart failure, it will be markedly elevated. If BMP or NT-proBNP is normal, it actually rules out that this patient has heart failure. Okay, other investigations include the cardiac MRI. Of course, MRI is not routine and it's not required actually to make diagnosis of peripartum cardiomyopathy. Echo is enough. But if the echo windows are not clear, or the echo is technically difficult, or if echo is not available. But I'm wondering, how would there be no echo and there will be MRI? So if there's no echo, there will likely be no MRI. So if echo is technically suboptimal, MRI is an option. Okay, but one thing about MRI is that there is what is called late gadolinium enhancement in patients with peripartum cardiomyopathy. Okay, and when late gadolinium enhancement is seen, it is associated with poor recovery, as in these patients who have gadolinium enhancements are likely not to recover are likely not to recover with time. Okay, now before older agents, contrast actually used for cardiac MRI used to be quite toxic to the fetus, but it's said that the newer agents are generally safe. Okay, so they can actually be done. Okay, invasive cardiac catheterization is not usually indicated. Okay, whether it is right or left heart. Right heart cath is not indicated because you can have an idea of pulmonary hypertension and the pressures from echo. Okay, so except if the patients are critically ill and they need a more detailed hemodynamic assessment, okay, before you can say you can do a right heart invasive catheterization. Of course, left heart cath or coronary angiography is not indicated. It is only indicated in which you are suspecting, in addition to the PPCM, you are suspecting coronary artery disease. Okay, and of course, you have to know that diagnostic coronary angiography in the cath lab exposes the patient to far more, if the patient is pregnant, exposes to far more radiation than a chest X-ray, more than 100 times or more radiation than the chest X-ray. So it's not advised. Okay, endomyocardial biopsy is generally not required because the diagnosis, like I said, can be made through other means. Okay, and there's nothing really that you say is pathognomonic or peripartum cardiomyopathy. Okay. However, you may see features of myocarditis if this patient has myocarditis. Okay. So in such patients, you will see things like myocardial hypertrophy and or degeneration. You may see fibrosis or even interstitial edema. Okay. Like I said, it's not indicated, but it's the decision to perform an endomyocardial biopsy should be left to the discretion of the physician and the patient. Okay. And of course, there's a risk of complication from an endomyocardial biopsy. And this risk, although it's low, but it's not reasonable to take such a risk for something that may not aid much in your treatment. You should consider genetic testing or genetic counseling and testing in those with a positive family history of dilated cardiomyopathy, those who have a positive family history of sudden death, or those who have a family history of peripartum cardiomyopathy. Okay, this is because approximately 10 to 20% of women with heart failure in the peripartum period, they are carrying these mutations unknown to them. So it's just that they now present when they are pregnant, maybe due to the hemodynamic stress. They've already been carrying the mutations associated with dilated cardiomyopathy all their life. Okay. And sometimes when they present like that, you will now find it difficult to differentiate from peripartum cardiomyopathy. What are differentials? Of course, peripartum cardiomyopathy, like we said, is a diagnosis of exclusion. So it's important to exclude other causes of heart failure in the age, in the locality where the patient is presenting from. Of course, the first thing you talk about, is there cardiomyopathy before? Okay, is there idiopathic dilated cardiomyopathy or familial dilated cardiomyopathy or HIV associated cardiomyopathy? Of course, HIV associated cardiomyopathy usually presents without ventricular dilation, and the commonest presentation or the commonest manifestation of HIV in the heart is pericardial effusion. Sometimes they may, under differential is pre-existing valvular heart disease, whether acquired or even congenital valve disease that can be unmasked by pregnancy, mitral stenosis, mitral regurgitation, whatever it is, you can actually also still present pre-existing undetected congenital heart disease, hypertensive heart disease with diastolic hypertensive heart disease with diastolic heart failure can also be a differential. Myocardial infarction, although because of how it will present and all that, may not be a close differential, but well, is a possibility. Then finally, pulmonary embolism. Pregnancy alone is a risk factor for venous thromboembolism and of course subsequent pulmonary embolism. So it's important to put all these things together. When it comes to treatment, the treatment goals are similar to those in patients with acute and chronic heart failure with reduced ejection fraction due to any other cause. Okay, so it's basically the same treatment, although there are now additional considerations because you are thinking about the baby, the drug you are giving, is it safe for the baby? Okay, what are the risks of the medication? What are the risks of the treatment? Okay, what's the prognosis like? You are thinking about what's the fastest way to deliver this baby that will be safe for both the mother and the baby. What time? How do we time the delivery? Do we do an elective CS? Do we do vaginal? Do we do assisted delivery? Okay, what's the mode of delivery? Okay, this one now, you now have to monitor the heart actively. Okay, if the patient is in labor and all that. Okay, you are looking at postpartum care. You are looking at the risk of counseling, the risk of future development of peripartum cardiomyopathy. So you have to counsel them. Okay, what are the risks needed? What are the risks if the patient wants to take in again and all that? Okay, then another thing you are looking at is what are the choices of medication? This medication you are giving, is it safe in pregnancy? Is it safe in lactation? Okay, and all that. So those are the different. But apart from these things, the treatment is basically the same as general heart failure treatment. Okay, so what are goals of treatment? We want to relieve symptoms. Okay, we want to reduce pulmonary congestion. We want to reduce the preload and the afterload. Okay, you want to, if you make a diagnosis of peripartum cardiomyopathy and the patient still has some time before delivery, you want to optimize the patient as much as possible and prepare the patient for a smooth delivery. Okay, then you want to also institute chronic therapies if you are able to, as much as you can, as much as safety and tolerability will allow you. You want to institute chronic therapies that will improve long-term outcome. One thing about this is that in the management of such a patient, there is a high-level multidisciplinary approach involving the obstetricians, the cardiologists, and so on. Okay. Then finally, you want to educate the woman about the future pregnancy risks. Of course, if the patient comes as an emergency, you give oxygen. If you need to assist ventilation, you go ahead. During the antenatal period, you should avoid the use of ACE inhibitors, ARBs, angiotensin receptor, and neprilysin inhibitor. You should avoid the use of sodium glucose 2 transporter inhibitors. You should avoid the use of mineralocorticoid receptor antagonists. All these are contraindicated in pregnancy. Okay. But however, diuretics, beta blockers, hydrolazine or nitrates, digoxin, and inotropes can be used for the treatment of peripartum cardiomyopathy during the antenatal period. So we are limited to these drugs because the others, either they have been proven to cause harm to the fetus, or the research is not enough to show that they are safe for the baby. Okay, now anticoagulation, antithrombotic therapy is not routinely indicated in patients who have peripartum cardiomyopathy, but there are some times or there are some situations where you will need to anticoagulate such patients. Of course, if you have a definite thrombus, you don't want it to progress, so you want to anticoagulate them, or if they have evidence of embolism, whether it's whatever it is, wherever it is, you want to do that. Okay, if they have atrial fibrillation, of course, atrial fibrillation has standard guidelines for anticoagulation. Okay, so you have to use the CHADVAS score and all that. Find if they also meet the criteria. If they do, fine, go ahead and anticoagulate. Patients who are taking bromocriptine, when we come to treatment, we'll see bromocriptine as one of the treatments. It's been found out that thromboembolic events, including stroke and myocardial infarction, have been reported as a complication of bromocriptine. So anybody who you are giving bromocriptine who has PPCM must be anticoagulated. Okay, let me talk about bromocriptine now. Bromocriptine is given at a dose of 2.5 milligram daily for at least 1 week in uncomplicated cases. And it can also be given as at a dose of 2.5 milligram twice daily for 2 weeks, then 2.5 milligram once daily for 6 weeks in patients who have severe disease, defined as left ventricular ejection fraction less than 25%, or features of shock. Okay, so in these patients, you want to use a higher dose of bromocriptine. Okay, so bromocriptine, although it has not been approved for routine use, but the initial, how would I put it now? The initial trials are saying that there's a greater improvement in ejection fraction following bromocriptine use. There's also improved mortality, okay, following the use of bromocriptine. Okay, I've said that bromocriptine must be given with an anticoagulant, and note that because of the way it works, it inhibits production of breast milk, and the woman will not be able to breastfeed. So you must look for other alternative sources of complementary or alternative feeding for the child. Okay, bromocriptine should not be used routinely for now. Okay, that's one source I said that because it's not been totally. More research is needed to completely tell us about the safety, the tolerability, and the effects of bromocriptine. All right. So talking about delivery, depending on the clinical status of the patient and the degree of fetal maturity. So there was something I was looking at the other day where about one of ESC guidelines for cardiac disease in pregnancy. Okay, so one thing they said was that so long as the patient doesn't have any obstetric indication, maybe fetal demise, maybe prolonged obstructed labor, or whatever it is that the ONG people have as indications for CS. Okay, if there's no ONG indication, the patient should be encouraged to do vaginal delivery because both of them, both vaginal or abdominal through cesarean section, both of them have their own issues actually. But as long as there's no obstetric indication and there's no other indication, the patient should go ahead and do a vaginal delivery. Of course, but this decision is not going to be made by one person. It's a multidisciplinary team, both the cardiology, the ONG, even the anesthetists and other people who may be involved. Okay, for peripartum cardiomyopathy specifically, if the patient is unstable and you can stabilize the mother prior to delivery, fine, go ahead, diuretics and all those things, oxygen, all the things you need to do to stabilize the mother, fine, you go ahead and stabilize the mother prior to delivery. But if still hemodynamically unstable, you need to deliver with the fastest load possible. It's my experience that in these patients who have cardiac disease in pregnancy, and whenever you take the load, most of them tend to just rapidly improve. Whenever I take by the load, I mean whenever they deliver the baby and the placenta. Okay, there is a rapid improvement in their symptoms, even almost all the cardiac disease in pregnancy. So the aim or the plan is to deliver as fast as possible. Okay. Now, if the patient is stable hemodynamically, okay, and there's no indication for cesarean, there's no obstetric indication for cesarean delivery, of course, we advise vaginal delivery with close hemodynamic monitoring and epidural anesthesia. Okay, I've said the other. Okay, when it comes to breastfeeding, if they are clinically stable, they can continue breastfeeding for as long as it's compatible with their cardiovascular medication. There's no contraindication to breastfeeding, but it said that ARVs should be avoided in breastfeeding mothers because of lack of safety data. Okay, so there are other therapies that, like I said, because of the role of interleukin 6, TNF alpha, CRP, and all that, they tried immunosuppressive agents, whether they can be of help, whether it's the biologics or the non-biologics, but they have not been seen to help in patients who have, although they are still under investigation. Even the use of IVIG, intravenous immunoglobulin, is still under investigation. Okay, so how do we manage these patients in the long term? Most of them will actually, 60% will achieve full recovery with appropriate treatment. Actually, they actually do very well. Patients with peripartum cardiomyopathy, most of them, 60%, with treatment and all that, they will have improvement in their ejection fraction and all that. They will do very well. Okay, so when they begin to do very well, you have to do what is called, since these patients are not patients who will be on heart failure medications perpetually, you have to wean them, you have to slowly wean them off medications for heart failure. Okay, so you consider weaning when the ejection fraction has stayed for more than 50%, when the ejection fraction is more than 50% for more than 6 months. Okay, that's when you consider weaning them off heart failure medication. Okay, and there is what is called a weaning protocol for peripartum cardiomyopathy, where you withdraw the medications one after the other. The first thing you stop, or the first thing you withdraw, is the MRA, spironolactone. Okay, you now continue beta blockers, ACE inhibitors or ARBs or ANI. Okay, if 6 months after stopping the MRA, everything is still okay, every function is good, patient is symptom free and all that, you can now withdraw ACI or ARB. Okay, so patient now will be on just a beta blocker alone. Okay, this now continues if patient is free on beta blocker, no symptoms, ejection fraction, repeated echoes, still good, more than 50% and all that. You now wean the patient off the beta blocker. But of course, we know that most of our patients, they wean themselves by themselves. You don't see them again. That's how you know that they are fine. All right, so if there is rebound, okay, you may need to now start all the medications again and restart this process. If you try to wean and you don't succeed, symptoms begin, ejection fraction tanks, you need to start the process again and continue the monitoring. Okay, of course, we know that for loop diuretics, thiazides, they don't really have for diuretics generally, they don't really have mortality benefit, so you can stop them at any time so long as the patient is clinically dry. Okay, so even if the ejection fraction is still low, but patient is not congested and all that, you can actually stop the diuretic and continue on other therapies that have mortality benefits. Just like other treatments, just like other causes of heart failure, sorry, the indications for device therapy or transplantation is similar. Okay, so it's still the same indications that you also have here. But for these patients specifically, you don't want to put an ICD, even though they are coming with a low ejection fraction, everything, because of the good prognosis. You want to see if they will recover. Okay, even if they have asynchrony, they meet the criteria, they have a left bundle branch block, you don't want to put a CRT yet. Okay, until after like 6 months to determine whether they will be able to recover, despite the fact that they meet the criteria at the point that you are meeting them. Okay, and just like any other, if they are refractory to all these things, refractory to guideline directed medical therapy, refractory to device therapy, whether it's a CRT, they are refractory to the LVAD or other forms of mechanical assist device. If they are refractory, you can actually consider cardiac transplantation if the symptoms persist despite maximal therapy, if they meet the indication. Okay, so one thing you must do for this patient is to counsel them on future pregnancy. Okay, they should be advised to take contraception seriously. Okay, they should be counseled on the risks of taking in fact, in patients who do not recover, who LV function doesn't recover, they are advised actually not to take in. They are advised not to take in. Okay. Okay. Now, in those who recover LV function after after delivery and all that, okay, they also have an increased risk of developing left ventricular dysfunction in subsequent pregnancies. So they should be counseled on this risk, counseled that even if everything comes back to normal, when they get pregnant, they should be seen and undergo frequent checks, okay, to catch it on time if they eventually become pregnant again. Okay, now there are some patients who also have persistent left ventricular dysfunction who do not recover. Okay, so these ones are advised to avoid being pregnant again due to risk of subsequent or heart failure, indeed, subsequent pregnancy that can lead to progression of symptoms and even death. Okay, so pregnant patients with a history of peripartum cardiomyopathy, like I've said, should be followed up in a multidisciplinary cardio and obstetrics program. So they should be followed up closely. Okay, even if everything is still fine and they've gotten pregnant again. And what's the outcome? The outcome for peripartum cardiomyopathy include maternal outcome, obstetric outcome, and neonatal outcome. Okay, of course, the main thing we want to avoid is maternal mortality and morbidity. Okay, and of course, compared to other pregnant women who don't have peripartum cardiomyopathy, there's an increased risk of mortality. Okay, ranges from about 1.4 to 3.4% within 30 days of diagnosis. And death due to peripartum cardiomyopathy, like death due to heart failure, is caused by progressive ventricular arrhythmias, pump failure. Okay, then they can also have sudden death, maybe due to a fatal arrhythmia, or even death from thromboembolic phenomena. Okay, whether they have an LV thrombus that embolizes and causes a stroke. Okay, what are the bad prognostic factors? If the NYHA class, what's NYHA class 4, very, very severe LV systolic dysfunction, less than 25%. Blacks, okay, because these ones will have genetic predisposition. If the patient is indigent, has no money, if the patient is multiparous, giving birth to 2 or more pregnancies, then increasing age, okay, women more than 30 to 35 years have a bad prognosis. Okay, what are the predictors of persistent left ventricular dysfunction when you follow up? Initial LV ejection fraction less than or equal to 30. Okay, if they have with fractional shortening less than 20%, an LV dilation more than 6 centimeters. Okay, if they have elevated cardiac troponin, hypotension, black, diagnosis during pregnancy, then if they have reduced right ventricular function, evidenced by TAPSE, low TAPSE, or fractional area change. Okay, then the patients with peripartum cardiomyopathy are likely to have more cesarean deliveries than others. That's the objective outcome. They're also likely to have, if they develop it in pregnancy, preterm birth less than 37 weeks. Although not so common, but still neonatal deaths are also slightly more common in patients with peripartum cardiomyopathy. In conclusion, peripartum cardiomyopathy, like I said, is defined as development of systolic heart failure towards the end of pregnancy or in the months following pregnancy with LV ejection fraction generally less than 45%, with the absence of any other identifiable cause of heart failure. The etiology is not known, but the final common pathway includes pathogenic factors such as angiogenic imbalance, altered prolactin processing. Okay, then different possible causes and contributions may come from genetic, inflammatory, hormonal, hemodynamic, infectious, and even autoimmune factors. In women with peripartum cardiomyopathy and heart failure, the goals of medical therapy are similar to those with heart failure, are similar to those in with heart failure with reduced ejection fraction due to other causes. Of course, other things you want to do include to plan the fetal race, planning around the pregnancy, labor and delivery, and counseling for future pregnancies. We have come to the end of the presentation. Thank you very much for your time.
Thank you so much, Dr. Okorie, for that brilliant presentation. Thank you so much for taking up the responsibility of this presentation, even though I called you in a short time. Thank you for being reliable. So the floor is open for contributions, questions from every other person. Thank you. You can unmute your mic and ask your question.
Thank you, Dr. Okorie, for that beautiful presentation. Please, Dr. Okorie, I don't know from what I have known, and then from that stuff that Professor Oga posted, it said it's actually, I don't know, it's younger maternal age, not older maternal age. So I don't know if you came across that. So women in their 20s, those are the people that are more at risk of having the PPCM. Again, with regards to breastfeeding, you said that they can breastfeed. So they are actually advised not to breastfeed, because the more they breastfeed, the more they release the 16 kilodalton prolactin, which is actually pathogenic. In fact, both the 16 kilodalton and the 23 kilodalton prolactin they are both pathogenic. So they are advised not to breastfeed. Again, with regards to the management, you said you withdraw the medication. To the best of my knowledge, there's a trial that was done. It says that once you remove the medications, that they seem to deteriorate. So rather than removing the medication, so they are on this medication for a long time. What you will rather do is to down titrate, but not to take them off the medication. At least that's what I know. I don't know if that has changed. Thank you.
Thank you very much.
Thank you, Dr. Okorie. Hello?
Okay, Doctor.
Yeah, please go ahead.
Yeah, thank you for brilliant presentation.
Ayodeji,
Sir.
Can you wait, let him respond to the concerns of Jennifer, so that we can trash that out?
Well, I think because it depends on which source. I know peripartum cardiomyopathy is more common in Nigeria, okay, than in other parts of the world, actually. So if what Dr. Jennifer is talking about are from studies done in Nigeria.
It's actually from Peace Registry, yes. Peace Registry, Dr. Kanye's, yes.
Yes, that's
So
where
it is like that.
Meant what Dr. Jennifer is presenting most time, most likely. I mean, sorry, not most likely. It's from the Peace Registry, but you presented a global vision of.
Thank you very much. Yeah.
So, Dr. Jennifer, it was the material I asked him to use to prepare.
Okay, no problem. Thank you.
That's why his presentation went this way. He presented it basically based on the global scale. But what you said, in fact, in that Peace Registry, they made mention of selenium, which he didn't see in this presentation.
Yes, there are so many things. There are so many practices that what they practice in the north, all those that are hot baths, which they say predispose these women to having that PPCM.
So
in fact, there's even the two-hit theory. You didn't talk about the two-hit theory, which is very, very important.
Didn't talk about the two-hit theory too. So what he presented is most likely from the material I gave him, which is the peripartum cardiomyopathy amongst the world generally. And so,
okay, no problem. Thank you.
So, but the breastfeeding actually is discouraged, even whether within the world or not. It's because of the same prolactin you talked about, which would actually worsen the recovery status of the patient when they have peripartum cardiomyopathy. We discourage them, and also the drugs you'll be giving to them, if they will be on diuretics and co, you might not really have enough breast milk. and some of them can be secreted in breast milk. So you, as much as possible, want to discourage breast milk and use other formula feeding.
Yeah.
But Dr. Jennifer, do you have that the document on the peace registry?
She be Professor Oga just posted it on our group now, residence page there. That thing that they presented at that this thing. Yeah, he posted it there. Look at it, you'll see it there.
You know that page. I know they check out like that.
Let me just send it to our own group. That stuff that they
Okay.
for Prof.
I didn't even look at this, so I would have looked at it.
It's
To have
there.
made the presentation richer.
Exactly. Yeah. So all the
okay. If he had actually looked at it, probably.
Hello.
Dr. Fatima.
Yeah, Dr. Charles, well done for the presentation. It's an excellent one. Thank you very much for that. Yeah, regarding Dr. Jennifer's comment, the issue of maternal age, the one you present is actually the age in the developed countries, but most of the studies done locally because of maybe early marriage and genetic predisposition, the fact that it's commoner in Blacks is usually in a younger age in our own race, in the Black race, particularly in Nigeria. And the issue of incidence, the highest incidence of PPCM is seen in Kano, which is 1 in 96 live births, while in Zaria it's 1 in 100. Do you understand? And with regards to the etiopathogenesis, it is not well defined. There is no single pathogenesis that is enough to explain the etiology of PPCM. That's why there are so many hypotheses as per the etiology. The issue of genetic predisposition, initially, the reason why PPCM was thought to be due to genetic susceptibility is because of the familial occurrence of the disease. But familial occurrence is not enough to say that, yes, PPCM is actually a genetic disease. That was why then genetic studies came up, where so many genes were looked into, including the titin, the ACE gene, the alpha-myosin heavy chain, the beta-myosin heavy chain, the sodium channel gene, the presenilin 2. So many genes were looked into, and there have been so many inconsistent results about the genes. So that's why still, even with the genetic susceptibility, it is not, you can't say this is the gene that predisposed to occurrence of PPCM. And other theories were actually done in female mice. They were not done in humans. So that's why they are all hypotheses. And the issue of prolactin, it was actually a study done in female mice where some of these female mice were knocked down of a cardiac specific tissue activator is it something called STAT3? So when they were knocked down of this gene, they were found to have high levels of cathepsin D. And the cathepsin D is the one that converts prolactin to 16 kilodalton prolactin. And this 16 kilodalton prolactin is the one that causes microvascular damage, especially in the heart. Hence, studies were done, but few studies were done, and in small number of patients, because these studies were done mostly in Germany, and they have few number of cases of PPCM, where they tested bromocriptine, which is a dopamine D2 receptor dopamine D2 receptor antagonist. This will block the binding of prolactin, thereby which showed improvement in this patient. But the fact that this study was done, there are just few studies, and they were done in small number of patients. So it's not enough to conclude that bromocriptine will treat PPCM. That's why it is still not recommended. And again, with regards to recurrence of PPCM in subsequent pregnancies, patients that have not recovered, meaning EF is persistently less than 50%, they have 50% risk of developing PPCM with subsequent recovery. While even those that have recovered have up to 25 to 30% risk of developing recurrence of PPCM. Hence, that's why it is always counseled that this patient should not undergo any subsequent pregnancy, because no matter what, they are still at risk of developing PPCM. And with regards to medication, these patients are usually weaned off gradually, as you rightly said, but there will come a time when they are totally off medication. Definitely, maybe after 1 year, you have done echo severally and they have recovered fully. They are usually off medication. It's not that they are on drugs for life. So this is my little contribution. Thank you.
Anyways, thank you so much, Dr. Fatima. I think most of the things you said, you already said them in the presentation. Dr. Jennifer, just the way Dr. Fatima highlighted, you're right. In our setting, it's basically for the younger age group. We in youth here, most of the PPCM we've seen is actually less than 30, most of them. So probably because of the prayer I gave him to prepare with, and he didn't quite have access to the peace registry. In the recent peace registry, it's actually the one I saw on net is more in Kano, followed by Zaria. So we should know that just the way Dr. Fatima highlighted. Dr. Ayodeji, please, sorry for keeping you waiting. You can make your comment or question now.
Thank you, Doc, for beautiful presentation. Well, on the pathogenesis, just like there are postulations, you didn't say anything about the viral infections. They said there are some cardiotrophic enteroviruses, like the Parvo B19, the CMV, and the EBV virus too. And then there's also this postulation about autoimmune and fetal chimerism. I don't know if you came across that. Then under your, just like the previous people said, the bromocriptine, even in the ESC20, is a class 2B, because it was just a small trial that was done in South Africa. And they noticed, of course, they had improvement with it. However, there was caveats to its use, because it was found to be, they had cases of embolic phenomenon, and some have the MI. So it has to be used with caution. And then on the prediction of, I don't know if you came across although pentoxiflozin is a trial drug, it's been shown to also improve the heavy function. So it's still in trial though. And then under the predictors of your heavy recovery, I know part of the absence of heavy thrombus too is also a predictor of good heavy recovery. And then when you diagnose the PPCM after delivery too, it's also a predictor of good heavy recovery. And then when you have a low BMP2 at diagnosis, it's also a predictor of good heavy recovery too. Thank you.
So Ayodeji, thank you so much. Please, what document are you assessing? Can you please share with us? And also, if you have the ESC guideline in soft copy, can you share with us on management of people?
Okay.
We'll be waiting for it.
Please, Chief Okopi.
Yes, ma.
Can I know why it's common in Kano? Please, what are the reasons? Is there any reason? Is there any particular practice which is I don't know, going on there that we need to know?
There are a lot of practice. And then apart from the practice we know, I think if Fatima can also contribute, there's selenium deficiency they've also found, which has been implicated also. And in fact, as part of the peace registry, they also have part of their objective is to look out for the effect of selenium supplementation to see if it will reduce the incidence of peripartum cardiomyopathy, from what I read in the peace registry. So I think with that multifactorial cultural practices and then some other dietary deficiency also have been implicated with respect to the prevalence. Or maybe because there's now increased awareness and diagnosis or something. But before it used to be the Zaria disease. My prof, Professor Dambauchi, was one of the few persons that made a lot of work on peripartum cardiomyopathy when I was in Zaria.
Good evening, please, Dr. Kopi, can I comment? I was looking for how to raise my hand. Forgotten how to raise my hand. Can I comment, please?
Yes.
On cultural practices, to the person who asked the question, I used to know that this heated salt beds that northern women used to be made to lie on was attributed to be one of the risk factors. I don't know if they've stopped that practice in the north, where after having a baby, the woman is made to lie on a salt bed, and the salt bed is hot. I don't know if you know that one, but that's the one.
There are a lot of
Yeah.
cultural practices from the peace
Dr.
registry.
Ugoze, let me comment about that.
A lot of cultural practices from the peace registry. One of them is the hot bath. Then there's the kunu. That's the wakanjeko, and then the potash.
They call it kawa.
Is it they take of this? What there is a kudu they usually
Hello.
take. What's the name? What's Dr. Fatima?
Yeah.
What's the name?
Let me tell you something. Yeah. Especially you that are going for West Africa. This issue of cultural practices, if you go through the peace registry, it has been downplayed. So whenever you are talking of cultural practices, tell them that that is in the past. Professor Karai hate to hear someone talking about cultural practices anymore. They have stated it clearly in the peace registry that during this study in the peace registry, they have found that these cultural practices are no more relevant. So whenever we come to discuss, he is always angry hearing people even talking about, in the peace registry, it is clearly stated that cultural practices, the issue of taking kununkanwa hot baths and lying on heated mud beds, that one has been downplayed. They are no longer relevant because studies have shown that they are no longer being practiced, but still people are coming down with the TPCM. Initially, there was theory of undernutrition, but that has also been scrutinized because this disease is still seen in people that are well nourished. So that's why the theory of malnutrition is also being scrutinized. However, selenium deficiency has been well documented in the peace registry, and selenium supplementation was seen to improve outcome in patients with PPCM. So that's what I will comment about the cultural practices.
Anyways, from what you are saying, is exactly what I've been trying to say, Dr. Fatima. The cultural practices are still ongoing. I just feel from when I read through the peace registry, it's just trying to reduce stigmatization of the northern people. Even though in exam, after reading through his peace registry, it will not be advised for us to emphasize on those cultural practices. But on a real note, when we really go through patients up here north, you still find those cultural practices being practiced. But from the peace registry, it's basically selenium deficiency and supplementation that was really, really emphasized. So in case we're going for exam and then it comes out that way, we may have to downplay. We can just mention it in passing if they ask us further. But if we need to emphasize anything, it's the selenium deficiency and supplementation. But on a real note, we still find those practices very common, sir. The hot bath, the kununkanwa, and then the wankanjeko. The wankanjeko is the hot bath, and then the mud, lying on the mud. They say it will help them wash away the bad blood.
Chief Okopi.
Hello?
Chief Okopi,
Yeah.
let me read what is written here. They said the previously implicated postpartum customary birth practices were not associated with PPCM in Nigeria.
It's just political. Dr. Afyong, please, can you speak? Dr. Godia, please, let's follow some protocol, please. Dr. Afyong has been up since.
I want to find out selenium part of the selenium. This is selenium deficiency. Can it be used?
Your network appears to be fluctuating. You said what?
Is selenium part of the treatment? Selenium.
Well, it's part of the peace registry. What one of the objective, selenium supplementation, and how the impact has been on improvements in left ventricular ejection fraction in PPCM. So it's not like it's part of the guideline-directed treatment. Dr. Godia, please, you can unmute and speak, sir.
Well,
she asked a question just and it's exactly what I wanted to comment on. The selenium supplementation. Actually, the study that was done by Kara on selenium supplementation that was given to patients who were already having PPCM does not show any significant improvement in their symptoms. There was no statistical significant improvement in their symptoms. So it was not recommended for the treatment. However, the selenium itself have actually been shown to be to be the driver toward the type of the cardiomyopathy that they have, but not to be used for the treatment. That was the study that was done and which was used later to incorporate in the peace registry. It's not for the treatment. That is what I understand about the selenium. And the mechanism of it's not only selenium actually alone, because they've also touted some other studies. Somewhere have touted deficiency of other micronutrients like zinc, and it was postulated that, or it has been documented that these micronutrients are actually needed for metabolism of thyroid hormone. So with deficiency of this micronutrient, the pregnant women, when they take in, of course, because of increased demand for this micronutrient for both the baby and the mother, the level tend to fall, and because of they are not getting it enough to replenish the store. That will lead to problem with thyroid hormone metabolism, and that was shown clearly. Have been documented that it affects it lead to the conversion of the alpha myosin to the beta myosin chain. Sorry, myosin, yes, which doesn't usually last long, even though it's stronger. And with that, remodeling will set in fast, and that is what usually led to the dilatation of the heart. And if that has happened, you give the selenium as at that time, it's not going to be very useful again. But if it's given before this process is setting, it actually helpful. So that is what I understand about the selenium that they use in the peace study.
Okay, thank you so much, Dr. Godia. Any further contribution
Sorry,
from
please, Dr. Kopi, please. Dr. Godia. Hello, Dr. Godia.
Yeah, I can hear you.
Please, what I saw there was that it didn't affect the primary outcome. All it did was that it reduced the symptoms of heart failure, not that it affected it had no effect on the primary outcome, but it reduced the symptoms of heart failure. So I don't know how that relates to what you just said now.
That's exactly what I'm saying, but I don't know where he maybe Dr. Godia can share that where you read it from because it's quite conflicting to what I actually know.
It's okay. I will share it.
All right, please. All right, thank you so much. Is there anybody with further contribution, please? Dr. Sori Conte, you know this is our disease, so I'm sure you are listening very well now. Do you have any contribution? Dr. Sore, please, if we are going for this exam, we should palm that, the way they presented it in this last MCS Northern stuff. And thank you, Obaswa, for pasting West African, the publication in the West African Journal of Medicine. Please, I also want to appreciate,
hello.
Doctor, sorry.
Yeah, sorry, my mic was mute. Thank you. I think a lot of work has been done in Nigeria, and from the last update course, I think one of the professors who was involved in that work was the presenter, and the issues he, I think, have been expanded upon. One thing I just want to mention is about the contraception after someone has been diagnosed with peripartum cardiomyopathy. Like the presenter mentioned, when the initial EF is less than 30, it denotes a worse prognosis and a very low chance of recovery from disease. So in such patients, it is recommended that you go for absolute contraception. And we prefer the tubal ligation mode of contraception because you are very sure that the person is not going to conceive. And because of the fluid retention effect of estrogen containing contraceptive, they are actually contraindicated for patients who have peripartum cardiomyopathy as a mode of contraception. And then also regarding monitoring the patient, for improvement in their ejection fraction and response to treatment, you depend a lot on echocardiography. Just some few practical points that, as the presenter mentioned, you can get some amount of wall motion abnormalities in peripartum cardiomyopathy that do not follow the contiguity of what you see in coronary artery disease. So because of that, when you're assessing your EF, using M mode and 2D might either underestimate or overestimate your EF depending on the portion where you cut the heart to get your measurement. So usually in these conditions, it is preferred to use Simpson method when you are doing your EF. I think those are just a few things I wanted to contribute.
Thank you so much, Dr. Conte, for that excellent contribution. Please, if there's any other thing from the updates you guys went through, you can help us from time to time to chip in so that we can have a comprehensive presentation. Thank you again. Any further clarifications or contribution from anyone? Dr. Jacqueline.
Yes, thank you, Dr. Charles, for the presentation. I just wanted to add that in pregnancy, since angiotensin-converting enzyme inhibitors and ARBs are contraindicated, the drug that supplements them in that case is the hydralazine nitrates, which reduces the preload and afterload. So when the person has given birth, then the patient should be changed to an ACE inhibitor, and the ones that are said to be safe in breastfeeding are enalapril and captopril. Then also wanted to mention that one of the reasons why vaginal delivery is preferred when the patient is stable is because there's more effect on hemodynamic shifts in those that undergo cesarean section. For instance, when they undergo cesarean section, there's this third space fluid shifts, and it's worse in those that have cesarean section, and also could occur in those that have vaginal delivery. And that's one of the reasons why most of the patients tend to present after they have already given birth, because of that hemodynamic change that occurs. It kind of now worsens the fluid that gets to the hearts and causes the cardiac myocytes to decompensate. Then also wanted to mention that the peace registry, probably one of the reasons why Professor Kare is discouraging the hot bath and all that as a cause of PPCM is the fact that there was a study, an earlier study done some years before the peace registry came in that had to do with them. I think they termed it peripartum cardiac failure, something like that. Is in the update material from last year. And it was found out that in most of these patients that presented with heart failure at that time, when they did like a review, because they called it peripartum cardiac failure, but when they reviewed how they actually made that diagnosis, they found out that most of them echocardiography was not done for them. And eventually when they checked, they found out that most of them had normal systolic function. So probably that's why they discarded the hot baths thing. But I probably will look more at that, look at the update material and understand it better. But I know I came across that in the update material. Then also to mention one of the
Do you have
sorry?
the update material? Do you have
I
the
do.
update material?
I do.
Can you share it on the group when you're done?
Okay,
Thank you.
I will. So one other pathogenic mechanism that he mentioned, apart from the prolactin theory, is the absence of STAT3 and also the selenium deficiency, which is part of the reasons that one of the things that they're looking out for in the peace registry. And basically these two mechanisms, the absence of STAT3 and the selenium deficiency, basically what they're looking at is the fact that when these things are absent or they're deficient, it increases the possibility of oxidative damage. So that's one of the theories that is implicated in the PPCM. So yes, that's basically what I have to. Then something else in breastfeeding, people with PPCM, they actually said that those that are in New York Heart Association class 3 and 4, that they discourage breastfeeding, but that for 1 and 2 is less well established as to whether they should continue breastfeeding or they shouldn't. So that's basically it. Yeah, thank you.
Thank you so much again for that added brilliant contribution. Thank you everyone for brilliant discussion today. Thank you. Dr. Ayodeji, please, you can share with us the ESC. I just want to recall some of the materials we're expecting on the group. Dr. Ayodeji, you have some materials, please. You can help us share the ESC guideline. And Dr. Jacqueline, the presentation. And then somebody wanted to speak, Dr. Lalekon. Olalekon, you wanted to say something? Okay, probably that was a mistake. I think so far, if there are still further contribution, please, you can unmute your mic and speak. Or if you need further questions and clarification, please. Okay, okay. We want to thank Dr. Charles. Dr. Charles, thank you so much, sir.
Yeah, Chief Okopi, thank you too.
Please, thank you for opening up this topic and giving us the opportunity to have a robust discussion. We are very grateful. I don't think we have any more questions to answer today. So this, we may have to call the class off today if there are no further contributions from anyone on this topic. So we'll just have the material needed to be shared on the page shared over time. By tomorrow, Professor Ladimeji will be with us. And then I think we may have like 2 presentations. And on Monday, we'll start the recall MCQ from West Africa through to national. In between, we'll be having presentation. We're expecting presentation from Dr. Conte, Heart as a Pump, and ACLS. We're expecting that from Alex Itubi. And then probably we'll roll out some more simple presentation to do. Thank you so much. If there are no any further information or announcement, none from my end, I should go for today.
Chief Okobi, please, this Prof's MCQ, there are 2 books. I don't know whether we're going to do the second one. I'm just asking.
Okay, the other one was not best of 5. I think it will be wise if we can go through it. Okay. Through and forth.
Oh, okay. I didn't know that.
Okay.
Okay.
So, but if we have time, we can go through it. But at least we have a recall of MCQ from the past exam, which we need to do. Okay, so please, Dr. Adebi is requesting for all the slides. We have Dr. Jacqueline, please help us with your slides. Dr. Okori, please post the slides. Dr. Ayodeji, please share the ESA guideline for management of PPCM and the other materials that you have. And if anyone has the peace registry full document, you can share it. Thank you. Please have a great evening. We'll see you again tomorrow.